I actually do have one question.
Go right ahead.
Um, a couple of attendings that I know wanted to jump into the Zoom, but they didn't have they weren't able to pre-register. Is it okay for them to join and see the presentations?
Absolutely.
Okay, great. Thank you.
Great. I believe we have everybody. Yes, Emily, I can see your screen. This is very professional, as you can tell. We will get started with the professional portion of our evening. I believe we have all of the presenters on. We are ready to start. Thank you so much for everybody who's joining us this evening. And we will get started with our first presenter, Amit. Is it Singal? Did I pronounce that correctly?
Yeah, perfect.
Perfect. Thank you very much. You are all set. Sorry, 1 second. I'm having some technical difficulties. Okay, there we go.
Thank you so much, Chris and Emily. Should I start now?
Yes, do so. Thank you.
Okay, great. Hi, everyone. My name is Amit Singhal. I'm a medical student at Rutgers, New Jersey Medical School, and also currently in my research fellowship at Will Cornell Dermatology, who I'm working with Dr. Sherry Lipner, who also is the leading PI on this project. I also would like to thank Rachel Hill, who is another medical student who helped with this project. So the title of the project that I'm going to be presenting is Exposure to 5-alpha reductase inhibitors or spironolactone in female alopecia patients is not associated with increased risk of gynecologic tumors. Ready for the next slide whenever you are. So just some background on why we decided to pursue this study. Androgenetic alopecia is the most common hair loss type in women. Typically, minoxidil and 5-alpha reductase inhibitors are commonly used as therapeutic agents for androgenetic alopecia. 5-alpha reductase inhibitors is a class of anti-androgen drugs that inhibits conversion of testosterone to dihydrotestosterone, or DHT in short, and it's more commonly studied in males than in females. Spironolactone is a blood pressure medication that is commonly used off-label in dermatology and can be used for female hair loss as well. Spironolactone is also an anti-androgen drug and has similar properties to estrogen. Now, the reason we wanted to do this study is because sex hormone abnormalities have been shown to be associated with breast cancer risk. So because of that, we wanted to see whether the use of 5-alpha reductase inhibitors and spironolactone increase the risk of gynecologic tumors in female androgenetic alopecia patients due to their anti-androgenic properties. Next slide, please. So to study this, we use the Trinetics Research Network. And for those of you that are not familiar, it is a global health collaborative research network that incorporates EMR records from over 100 healthcare organizations worldwide, but mostly from the US. To build our study, we used ICD-10 coding and ATC coding. We isolated female androgenetic alopecia and other non-scarring hair loss types of all ages. We separated them based on exposure to 5-alpha reductase inhibitors, spironolactone, or minoxidil, which we use as our controls. And you can see the different numbers of patients in each one of our cohorts. Each cohort was matched to minoxidil based on current age, diagnosis age, race, ethnicity, weight, diagnosis of PCOS, past pregnancies, menopause, alcohol disorders, and exposure to hormonal treatments to reduce the effects of those variables on the outcome. And then an odds ratio analysis was performed to see the risk of gynecologic tumors any day after the initiation of the drug. Next slide, please. So before we go to the meat of the study, just to characterize our cohort a little bit more, in the table, you can see the characteristics of the 5-alpha reductase inhibitor exposed group, the spironolactone exposed group, in the minoxidil exposed group, which again is served as our controls. In short, the 5-alpha reductase inhibitor control compared to minoxidil tended to be older. So that suggests that older patients tend to be prescribed 5-alpha reductase and more often white. And the spironolactone compared to minoxidil tended to be younger and also more often white. And then after matching, as I mentioned previously, all the demographics were more not statistically significant, so they were well matched. Next slide, please. So when it comes to the odds ratio analysis, we found for the 5-alpha reductase exposed cohort compared to the controls, the minoxidil, there was no difference in the odds of developing any of the malignant cancers, including breast, endometrial cancer, and ovarian cancer. And we know that because if you notice the confidence intervals, they cross over 1, which means there's no statistical difference. We saw the same thing with the spironolactone exposed group compared to minoxidil. No increased risk of any of the malignant cancers. And we also analyzed for the risk of developing benign gynecologic tumors. And for both the 5-alpha reductase exposed group and the spironolactone exposed group, we saw no increased risk of any of the benign tumors. So the key takeaway from the study is that we did not find any increased risk of any of the gynecological tumors, malignant or benign, with exposure to 5-alpha reductase inhibitors or spironolactone compared to the controls, the minoxidil exposed patients. And thus, patients could be reassured that they may not be at increased risk of gynecologic tumors with exposure to these medications. I thank you for listening to my talk, and I'll take any questions now if anyone has any.
Doesn't sound like it, but we can come back at the end if somebody has some questions. We will move on to Stefano DiCenso. Was that correct, Stefano?
That was spot on. Thank you.
Thank you.
So my name is Stefano. I'm a medical student at Case Western and a research fellow at the University of Arizona. And I will be talking about the risk of androgenic skin conditions with the use of long-acting progestin contraceptive devices. Next slide, please. So some background, the link between the use of systemic progestins and an increase in the risk of androgenic skin conditions such as acne, hirsutism, alopecia, and rosacea is well established. But what is less clear is whether the use of the commonly utilized LNG IUD or the ENG subcutaneous implant is associated with that same risk. Some studies over the past 10 years have shown an increased risk of those conditions with both of these devices, but a recent study actually demonstrated a protective effect against the androgenic skin condition of melasma in patients that were using progestin IUDs. So it's very mixed. So why is this relevant to women? So unintended pregnancy remains a significant issue in the United States. And despite there being these highly efficacious contraceptive devices, they're still significantly underutilized in women that are using contraception. And so thoroughly investigating their risk profile for these types of androgenic conditions may help alleviate some patient concerns and potentially increase their utilization kind of across the board. So the aims of our study was to first compare the risk of those 4 androgenic skin conditions I mentioned in the year following implantation with either an LNG IUD or ENG implant relative to a non-hormonal copper IUD control. And then the second aim was to do a head-to-head comparison of the risk. Next slide, please. So methods like Amit before me, we also use the Trinetics platform, which is a large database that contains de-identified electronic health records information from millions of patients in the US. And here on the right, I have the strobe diagram, which just shows the queries, each of the queries that we put into the database to ultimately generate our last 3 cohorts of interest, which would be the ENG implant cohort, the LNG IUD, and then the copper IUD cohorts at the time of their implantation. Next slide, please. So One benefit of the Trinetics database is this propensity score matching feature, which takes baseline demographic or health characteristics and attempts to reduce them to insignificance before you do any kind of analysis. So here are the results of our matching, and most of our characteristics were controlled for at baseline. There are a few demographic characteristics that remain significant, but one thing to note is that the tests for significance are very sensitive to sample size, and we had very large sample sizes in each of our groups. So we think that the clinical significance of these differences is minimal. Next slide, please. So the results, we took those propensity score matched cohorts and then compared their 1-year risk of each one of those conditions. So the first analysis was the ENG implant versus copper IUD, and we found that the risk of non-scarring alopecia and hirsutism was reduced in the ENG implant cohort. And then for acne and rosacea, those were also very close to significance. For the LNG IUD versus copper IUD analysis, there was no difference in the risk of all 4 of these. However, this is still different from prior studies that demonstrated that there was an increased risk of these conditions with the use of LNG IUDs. And then for the head-to-head comparison, the ENG implant versus LNG IUD, we found that the implant was associated with a decreased risk of acne, hirsutism, and rosacea. And next slide, please. So in conclusion, both of these contraceptive devices had a low absolute risk of these androgenic skin conditions. In contrast to prior studies, the ENG implant was actually associated with a decreased risk of these conditions. There's no increased risk in the LNG IUD cohort. And then the ENG implant in particular might be a great option to offer patients that are particularly concerned about these cutaneous side effects, or patients that have a history of them, and we can hopefully encourage more patients to utilize these highly efficacious contraceptive devices. And that is the end of my presentation. Any questions?
Thank you, Stefano. We will come back at the end potentially. Our next presenter is Molly Wallace.
Hi, everyone. My name is Molly Wallace. I am a current research fellow at Thomas Jefferson University under Dr. Anita Nickbott, and a medical student there as well. So what we looked at was the increased risk of new onset alopecia in patients taking glucagon like 1 peptide, 1 receptor agonists. Next slide. So what inspired this project, this conference actually inspired this project. One of my mentees and I were sitting thinking about a good project that applied to women's derm, and there's been so much social media and news about GLP-1s in the last several months and years. And we started looking into it, and there was recently a call to action published in September 2024 by Desai et al. Discussing discussing a need for a further investigation into these reports of hair loss with these GLP-1 agonists. So in 2021, the FDA approved semaglutide for weight loss. It was the first GLP-1 approved for weight loss. And since then, the prescriptions for GLP-1s have continued to surge, and along with the increased prescribing of GLP-1s have been increased in side effects. And a lot of them are anecdotal, as they haven't been investigated, and this is a very hot topic online. A lot of patients are discussing their experience with these medications on TikTok. So there's a lot of talk out there, but there's no existing data currently in the literature investigating the risk of hair loss with these medications. And it is something a lot of people are talking about. So what we wanted to do was use Trinetics, which everyone is familiar with now, to investigate whether or not there is this increased risk of hair loss with GLP-1s. And then it looks like my slide got cut off, but the relevance to women is hair loss can have a disproportionate emotional and social impact on women due to the societal standards that women face. And additionally, women have largely been left out of hair loss studies in the past. So our study focused on women primarily. And the effect. That's why we wanted to look into this. Next slide. So again, like I mentioned, we used the Trinetics database and we created created three separate comparisons. We had a control group which consisted of adults with 2 prior healthy visits at the PCP, and then we had a GLP-1 group, then we had a metformin group. As we know, GLP-1s are also used for diabetes, and that is also what GLP-1s can be used for in addition to weight loss. So we had one group comparing metformin and GLP-1s, and then bariatric surgery is kind of like the last resort for weight loss for many patients and is associated with the highest degree of weight loss among all these groups. So we created these separate cohorts and then did propensity matching for age, race, and sex. Additionally, we excluded patients less than 18, pregnant patients, and patients on chemotherapy. And then we looked at new hair loss diagnoses using the ICD-10 codes L63, L64, and L65, and then compared the relative risk of hair loss within each group. And additionally, we ran subgroup analyses investigating what the different types of hair loss that had the different types of hair losses in each group and the relative risk of each. You can go next slide. So these are our results. As we can look at our demographics, the majority of our cohort was female in each comparison, and the majority of our patients were white in each comparison. When looking at the relative risk of GLP-1s, androgenic alopecia was the most significant across all cohorts, with non-scarring alopecia being next. Additionally, we noticed the highest degree of androgenic alopecia when we compared GLP-1s to controls. And then additionally, the highest risk of relative risk of the next highest relative risk of androgenic alopecia when comparing GLP-1s to bariatric surgery. You can go next slide. So what we took away from this study was that GLP-1s approved for weight loss have a statistically significant relative risk of new onset alopecia when compared to metformin, healthy controls, and bariatric surgery. And this was actually not what we hypothesized was going to be the case. When we were hypothesizing for this project, we thought that, this is most likely telogen effluvia, and we know that when you lose weight, you have life stressors, changes in nutritional intake that can cause telogen effluvium. So that's what we thought this was. And our results surprised us with androgenic alopecia being much more significant than the other types of hair loss. While GLP-1s for weight loss and diabetes impact female hair while GLP-1s are effective for weight loss and diabetes management, their impact on female hair health warrants further investigation with prospective studies. And also as providers, discussing with our colleagues, and if we have a patient coming in with new onset hair loss, doing a thorough history and looking at patients' recent medications or whether or not they've recently been on a GLP-1, so we can properly educate our patients that this is actually a side effect of these medications. And then I think that's it.
Okay, hi everyone. My name is Bianca. I'm a third-year medical student from the University of British Columbia, which is in Vancouver, Canada. And I'm excited to present our project titled Gender, Race, and Ethnicity in Academic Dermatology in the United States, a longitudinal analysis. Next slide, please. So studies show that diversity in healthcare is important for improving access, patient outcomes, and the physician-patient relationship. And although there's increasing female representation in medical schools and within physicians, women continue to be underrepresented in senior ranks and leadership roles in medicine, and this is also true within dermatology. Furthermore, despite the growing diversity of the US population, the proportions of racial and ethnic minorities among medical schools and in practicing physicians don't reflect the population demographics. So for this reason, we examined 56 years of gender, racial, and ethnic representation trends in academic dermatology to address gaps in diversity and equity. Next slide, please. So we conducted a longitudinal analysis from 1966 to 2021 using the AAMC faculty roster for full-time dermatology faculty to look at the percent composition of dermatologists across academic ranks. So that would mean like professor, associate professor, assistant professor, and instructor, leadership positions, and tenure statuses. And then we used linear regression to look at changes in representation over time and compared 56-year means for gender, race, and ethnicity. Next slide, please. So in 2021, the majority of academic dermatologists were female at 52.5%. There was an increase in total female positions over the 56-year period by 0.93 percentage points per year on average. However, this increase was slower in senior academic ranks, leadership positions, and tenure. And this growth was faster in junior academic ranks, such as associate professor, assistant professor, and instructor. In 2021, there was still a greater proportion of male dermatologists in senior academic ranks, leadership positions, and tenure. And when you looked over the 56-year means, there were significantly more males than females in total across all academic ranks, leadership positions, and tenure statuses. Next slide, please. With regards to ethnicity and race, the majority of academic dermatologists in 2021 were white, making up 66.7% of all dermatologists. Over the 56-year period, there was an increase in representation of total Asian, Black, and Hispanic dermatologists. However, there was still a greater proportion of white physicians with senior academic ranks, leadership positions, and tenure. And when we compared 56-year means, there were significantly more white than any other racial or ethnic minority physicians in total across all academic ranks, leadership positions, and tenure statuses. Next slide, please. So in conclusion, we showed that over this 56-year period, gender and racial and ethnic disparities still persist in academic dermatology. Female and racial and ethnic minority representation in academic dermatology positions increased over time, but the increase was slower in senior academic ranks, leadership position, and tenure. Recommendations have been proposed to continue supporting minorities in dermatology, such as establishing departmental diversity task forces, providing incentives for mentoring and sponsorships, and for building cross-institution networks. But further studies are still necessary to identify barriers and provide support for female and racial ethnic minority dermatologists to attain higher ranks in their field. Thank you all for listening. Special thanks to my team, Dr. Joseph and Dr. Kosa, especially for including me on this very important project. And I am happy to answer any questions later on.
Thank you. Mara Hartoyo, did I say that correctly?
Yes, thank you. Hi, everyone. I'm Mara Hortoyo, a second-year medical student at the University of Miami Miller School of Medicine. I'm here today to present the preliminary results of our survey study, Perceptions and Limitations of Skincare in People with Skin of Color. And this project is under Dr. Alex Rosen-Aiken. Next slide, please. So just a little bit on the background of our study. As we all know, media advertisements heavily influence how we buy skincare products and what we choose to buy. And a lot of times people with darker skin tones are underrepresented in these advertisements. And this underrepresentation extends to essential skincare products such as sunscreen and moisturizer. This underrepresentation disproportionately impacts women as they make up the large majority of the skincare consumer market. And having less options available to you could lead to decreased compliance with a daily moisturizer and sunscreen regimen, which is essential to skin health. And our study takes a focused look at women as they comprise over 80% of our participant pool. Next slide, please. So just a little bit about the methods. We have been collecting surveys from patients at multiple University of Miami dermatology clinics. And so far we have 72 surveys. So we did a preliminary analysis of these responses. And we're just looking at whether or not there's associations between skin tones and perception of skin care and dermatologic care. We grouped participants into either a lighter skin tone group or a darker skin tone group for comparative analysis. And the darker skin tone group included participants with Fitzpatrick skin types 5 and 6. And we used simple logistic regression and multivariate analysis just to see if there's any associations and to quantify those associations between skin type and perceptions on skin care. Next slide, please. We did have some interesting results already. So we found that when comparing individuals with lighter skin tones and darker skin tones, we saw that individuals with darker skin tones were 16 times more likely to feel that there's an inadequate availability of products that are focused or adequate for their skin type. And additionally, we found that people with darker skin tones were 7 times more likely to want to buy from brands that have inclusive advertising. And when looking at the women, they were 7 times more likely when compared to men to be also influenced to buy from brands that are more inclusive in their advertising. And also interestingly, 4 times more likely to prefer a dermatologist with the same skin tone as them compared to men. So overall, we did see that underrepresentation in advertisements is affecting the purchasing choices of people with darker skin tones. Next slide, please. So our results showed that this lack of inclusivity in skincare product advertisements might influence purchasing choices for people with darker skin tones. And this can lead to a limited perceived availability of products. And especially for essential skincare products such as moisturizer and sunscreen, they vary greatly in quality and ingredients across different brands. So a wide range of options is essential to finding a skincare regimen that people will stick to and that they feel confident with. A limited availability of products for people with darker skin tones may lead to decreased adherence to daily sunscreen and moisturizer regimens, and that can result in suboptimal skin health. So overall, it's really important to increase awareness amongst dermatologists about brands that have inclusive advertising and that cater to all skin types and skin tones so that dermatologists can then advocate these brands to patients and allow for everyone to have adequate options for an skincare routine. Thank you, everyone.
Thank you. Next is Ajay Dulai.
Hi everyone, my name is Ajay. I'm a recent medical graduate and also a sub-investigator working in dermatology clinical research with Dr. Sivamani. I'm super excited today to be presenting our systematic review and meta-analysis on maternal JAK inhibitor usage and their associations with fetal outcomes. I'd like to say thank you to all my co-authors and also WDS for letting us present today. So JAK inhibitors are a relatively new class of medications currently approved within dermatology for psoriatic arthritis, vitiligo, atopic dermatitis. However, they have many more applications outside of dermatology. Also working in clinical research, I've seen some super exciting results for JAK inhibitors in other diseases within dermatology. So I'm really excited for the future of this class of medications. So early animal studies did show teratogenic effects, including increased risk of congenital malformations and post-implantation pregnancy loss. The biologics, which are their main comparator medications, are generally considered safe during pregnancy. So it's really important that we pool together all the human fetal outcomes that we have so that we can guide clinical decision-making in picking which medication is best in a woman of childbearing potential. Furthermore, about 50% of pregnancies in the USA are unplanned, so it's important that our clinicians have a super clear idea of these side effects so we can properly counsel our women of childbearing potential on the risks if they were to get pregnant. Next slide, please. So we performed a systematic review of 3 databases in which we identified 212 articles. After going through our inclusion and exclusion criteria, we found 17 articles that satisfied it for a total of 319 pregnancy outcomes. Our 2 main outcomes that we were interested in was the rate of congenital malformations and the live birth rate. The live birth rate is defined as the total births minus the spontaneous abortions minus stillbirths divided by the total births. We also calculated these 2 outcomes for the general population and for pregnant women taking biologics that we had a comparator group. Next slide, please. So when considering the live birth rate, we did find a significantly lower JAK inhibitor live birth rate compared to biologics, but not compared to the general population. When considering congenital malformations, we found no difference compared to biologics or the general population. We also calculated the odds ratios, and we plotted these on these forest plots you can see here. On the left, we have the odds ratio of an abortion or stillbirth when taking a JAK inhibitor instead of a biologic. And you can see increased statistically significant increased odds ratios for all the JAK inhibitors and for overall JAK inhibitor usage. We didn't perform a sub-analysis on ruxolitinib due to the limited cases which we found. On the right, we compared biologic usage and JAK inhibitor usage to the general population, which found no statistically significant changes in the odds ratio. However, this is a little bit harder to draw takeaways from as there's so many confounders in the general population. Next slide, please. So in summary, we found an increased risk of spontaneous abortions in JAK inhibitor usage. Thus, we do think it's really important that clinicians counsel women of childbearing potential on these side effects. In line with this, we also recommend the usage of 2 effective forms of contraception when using JAK inhibitors in this population, and also the consideration of using a biologic if they're worried about this. So JAK inhibitors are still relatively new. We need to continue to assess cases as they're published and as new JAK inhibitors are created. We also found a lack of evidence into topical formulations, particularly of ruxolitinib, which theoretically would provide less systemic side effects while kind of still giving that efficacy. So this could be a great potential option for women of childbearing potential. Thank you so much. Are there any questions for me? Thank you.
Thank you. Our next presenter is Hiba Bashir. Is Hiba on? Okay, we will skip to our next presenter and come back. Milan Hirpara.
Hello, it's actually pronounced Milan Hirpara. Thank you, though.
I apologize.
No worries. Hello, everyone. My name is Milan Hirpara. I'm a medical student at the California University of Science and Medicine and a current research fellow at the University of California, Irvine for the Department of Dermatology. Today, I'm going to be presenting on our team's study titled Hidradenitis Suppurativa in Hispanic Patients, Clinical Characteristics and Comorbidities. Next slide, please. Thank you. Hidradenitis suppurativa, or HS, is a chronic inflammatory skin condition characterized by painful abscesses and sinus tracts. HS is believed to be underdiagnosed in the Hispanic population, which may be due to limited access to healthcare, lack of awareness of symptoms among patients, and possibly misdiagnosis among primary care providers. In fact, previous research has shown among Hispanic patients, the average diagnostic delay of HS is 4.7 years compared to 3.2 years in Caucasian patients. Considering the Hispanic population is growing by 2% annually, faster than most non-Hispanic groups, we conducted a study to identify comorbidities and dermatological conditions associated with HS in Hispanic patients. This study is relevant to women because HS disproportionately affects women overall, and the associated physical and social burdens of the disease are compounded by societal beauty standards for women. Next slide, please. Thank you. So we use the US collaborative network consisting of 69 healthcare organizations from the TriNetX database to construct Hispanic and non-Hispanic cohorts with HS from November 2006 to November 2024. Data on sex, age, and ethnicity and comorbidities were collected and compared between cohorts through a Fisher's exact test. And next slide. Our Hispanic cohort included 16,387 patients with 76.8% female, and the non-Hispanic cohort included 174,047 patients with 76.6% female. Our results showed that Hispanic females demonstrated a significantly higher prevalence of HS than non-Hispanic females. On the other hand, Hispanic males demonstrated a lower prevalence of HS than their non-Hispanic counterparts. Age of diagnosis was also significantly lower in the Hispanic cohort, specifically an average of 29.7 years in the Hispanic cohort versus 36.5 years in the non-Hispanic cohort. 3 comorbidities that were more prevalent in the Hispanic cohort were obesity, 32% versus 25%, acne, 9% versus 7%, and dermatitis, 7% versus 15%. However, hypertension was significantly greater in the non-Hispanic cohort, 14% versus 21%. Next slide, please. So in conclusion, key hallmarks of HS in Hispanics seems to be being female, younger age of diagnosis, and obesity, along with a greater prevalence of acne and dermatitis compared to non-Hispanic HS patients. Our findings emphasize the need for public health initiatives directed towards educating Hispanic communities on risk factors and symptoms of HS, promoting early diagnosis and early evaluation for associated comorbidities. And next slide. And I just want to thank Dr. Mezenkovska and the rest of our team at UCI for making this possible. And of course, thank you all for your attention. And if you have any questions, I'm happy to answer.
Thank you. Our next presenter is Hannah Englander. Sorry if I mutilated that.
No, that was good. Hi, my name's Hannah. I'm a second year medical student at UMass Chan Medical School, and this is my group's work on our ongoing pilot study under the guidance of Dr. Dory Goldberg, focused on empowering skin health through outreach at a local women's shelter in Worcester, Massachusetts. Next slide, thank you. So just some background. This was a pilot study. It's in its initial phases, but the main goal has been to determine the impacts of outreach on healthcare attitudes and trust among the women at the Jana's Place Women's Shelter. And this is a women's shelter in Worcester, Massachusetts. It's about 5 minutes from our medical school, and it specifically serves women who are suffering from specific traumas, including substance use, domestic violence, or mental health disorders. Next slide. Thank you. So what we've done, there's about 16 women at the shelter so far, and so we've offered optional surveys, and we've been very fortunate that all the attendees are very eager to participate. So we've offered them to all these women who are at the shelter, both at the beginning and end of an educational 1-hour workshop session where we present on a variety of dermatology related seminars. And sometimes we pick these sessions. Sometimes we ask the women if they have a preference. And sometimes they have, we gave a talk once on drugstore savvy skincare products. That was a real hit with them. But other ones we've done have focused a lot on skin cancer detection and prevention, scalp hair health, as I said, drugstore savvy skincare products, and different types of sunscreen, and explaining differences between chemical and physical. And we collected this data from our surveys and managed it in REDCap. And next slide, please. Thank you. So far, this is the data we've collected, and what you're seeing is both a pre and post survey answers to a variety of questions, as you can see on the right here, mainly asking how would you rate your current understanding of what skin cancer is and its potential harm, comfortability with assessing moles and abnormal appearances of them, rating understanding of what prevents skin cancer. So obviously focusing on sunscreen and other ways to mitigate sun risks. How confident are you in taking appropriate actions if you notice in your changing mole? How likely are you to take steps to prevent sun exposure or wear sunscreen? And then how likely are you to complete regular skin checks and having access to a provider who can do so? So we've collected the data here. Again, this is a preliminary study, so we can't say with extreme confidence anything. So these are just more so trends that we're showing here, but you can see the difference between pre and post survey. The answers have gone up, which is, what we would hope. So next slide. Thank you. So far our trends have shown that the level of understanding on harm and prevention of skin cancer remains roughly the same. Direct community intervention with health education helps to increase residents' knowledge of recognizing concerning moles. And, the big thing and main takeaway that, we want to continue to implement here is that education makes it more likely that individuals will take action to seek healthcare when concerns arise. So, that's the ultimate goal here. And we have monthly seminars where we go back and, we've been able to help a lot of these women get primary care doctors and access to dermatology checkups. So it's been a very fulfilling project, and I thank my mentor for taking the lead on supporting this, and then my team who's helped to give these presentations. Thank you.
Thank you. Our next presenter is Michael Ong.
Hi, everyone. My name is Michael Ong. I'm a medical student at Weill Cornell, and the title of my talk is Increased Anti-Nuclear Antibody Positivity in Central Centrifugal Cicatricial Alopecia Patients. And this research is conducted under the guidance of Dr. Sherry Lipner. And special thank you to Amit, who we heard from earlier, for helping with this project. Next, please. So just some background, central centrifugal cicatricial alopecia, or CCCA, is a form of primary scarring alopecia that predominantly affects Black women. And this research was inspired by a study that was recently published that looked at clinical and laboratory results in CCCA patients and found an increased prevalence of ANA positivity in CCCA patients. And in terms of relevance to women, CCCA, like I said earlier, does predominantly affect Black women, making this a significant concern within this demographic. And understanding and addressing the CCCA can then lead to better targeted treatments and support those that are most affected. Also, these possible autoimmune associations can potentially benefit women that have other similar autoimmune conditions. Next, please. So for the methods, we also use Trinetics Research Network, and we searched for Black women with CCCA and Black women with other primary scarring alopecias who served as controls. For patients with CCCA, because there are no ICD-10 specific codes, we had to use L66, which is just an umbrella cicatricial alopecia code, and we excluded patients with known primary scarring alopecia. And then we did the opposite for patients that were for our controls, where we then only included patients with known primary scarring alopecias. In both cohorts, we excluded patients with discoid lupus because that is an autoimmune disorder as well, which can be confounding. And for statistics, we did propensity score matching based on current age and age at diagnosis. And we analyzed their autoimmune conditions 1 day or greater after their alopecia diagnosis and used Benjamini-Hochberg procedure to adjust for multiple hypothesis testing. Next slide, please. So this is the first part of our results. In total, we analyzed 5,811 CCCA patients and controls each. And we found that CCCA patients versus controls were older at diagnosis. CCCA patients were about 48.6 years versus 45.6 years in our control group. We also found a decreased risk of diabetes in these patients. CCCA patients had 2.9% prevalence, while other primary scarring alopecia patients had 4.8% prevalence. And in terms of ANA positivity, before diagnosis, we had 0.7% of CCCA patients and 0.2% of controls had positive ANA. Next slide, please. And this is looking at autoimmune disorders within our patients after their alopecia diagnosis. And in this cohort, we found very similar results with the type 1 diabetes, where fewer patients had type 1 diabetes in our case group. So the CCCA patients had 0.8% prevalence, while controls had 1.3%. And we also found increased risk of systemic lupus erythematosus at 0.9% versus controls who only had 0.3%. Next slide, please. So in conclusion, we found that CCCA may be associated with higher prevalence of ANA positivity and systemic lupus erythematosus, and that CCCA is not associated with most autoimmune disorders. And what this means for dermatologists is that they should consider screening for ANA in CCCA patients if a review of systems is concerning for systemic lupus. Some limitations of this study, because this is a database study and everything is kind of binary in the ANA titer, we don't actually know what their levels were. So some of these may be weakly positive. And at the time of this study, there were no CCCA specific ICD-10 codes. I believe late of last year, that was recently approved, but at the time of this study, we were not able to use that ICD-10 code. And then also CCCA is a clinical pathologic diagnosis, and Trinetics does not have histopathological confirmation of CCCA. So we're not 100% certain that these patients have CCCA.
Thank you, Michael. Our next presenter is Taylor Miller.
Hi everyone, my name is Taylor Miller and I'm a second-year medical student from the Geisel School of Medicine at Dartmouth College. And today I'll be presenting a systematic review on the performance of machine learning on basal cell carcinoma with Mohs frozen sections. Next slide, please. So overall, basal cell carcinoma is the most common form of skin cancer, and its incidence among women has doubled in recent years. Mohs is the treatment of choice for most of these lesions due to its efficacy and the real-time margin analysis, which enables same-day closure, yet the process of Mohs is very resource-intensive, which may leave a role for machine learning to help improve the workflow efficiency and outcomes for patients. While most of the initial investigations of AI within medicine were solely diagnostic, common in fields like radiology and pathology, it's important to consider the potential benefits from implementing these technologies in resource-intense procedures such as Mohs. Next slide, please. For our methods, 2 independent reviewers performed the screening for all steps of our review. And in the Prisma flowchart on the right, you can see our initial search from 2 databases yielded 346 articles after the removal of duplicates, and ultimately only 7 met our inclusion criteria. We use validated risk of bias assessment tools Tripod and Probast, which were adapted to fit the machine learning and AI landscape and used to assess bias for all of our included studies. Next slide, please. Our results yielded an area under the curve average of 0.91 with a range from 0.75 to 0.99, demonstrating high diagnostic accuracy of these models for basal cell carcinoma slides. Among the studies that reported their slide counts, training and validation was performed on an average of 303 slides, and the machine learning models were tested on an average of 60 slides. The majority of the included studies had an independent test set, and 1 had a prospective test set, and 0 had external test sets. There was variability seen in the validation schemes utilized and the ground truth determinant. The holdout method was the most common validation scheme used, and a Mohs surgeon was the most common determinant of the ground truth for the machine learning models. I want to emphasize that while seeing some variation within these parameters is to be expected, small differences in the methodology and the area of interest when looking at these models and asking them to make a diagnosis can have large impacts on the performance and the realistic implications of these technologies within Mohs workflow. Overall, our review concluded that machine learning can perform with high diagnostic accuracy for basal cell carcinoma on these frozen slides. However, there was extreme variability seen in the reporting of method design, specifics for the data sets, and model performance metrics, which limits the conclusions that can be drawn from our review. A simulated retrospective study showed that there can be evidence that integration of these technologies could improve the efficiency of Mohs, saving time for the slide, the staff, and the technician.
Thank you, Hannah.
Future research. Future research investigating these technologies should emphasize the standardization of reporting both the methodology and performance metrics, including prospective and external test sets, simulating the integration into Mohs workflows, and applying similar technology to other skin cancers. In conclusion, more research is needed to determine the use of machine learning within dermatology and specifically assisting during resource-intensive procedures like Mohs, but we should continually prioritize integration into existing workflows, improving the efficiency, and improving patient outcomes. Thank you, and this time I'll take any questions.
Thank you, Hannah. Our next presenter is Nicholas Leal.
Yep, you got it. Thank you. Hello, everyone. My name is Nick Leal. I'm a medical student at the University of Arizona in Tucson. Thank you, WDS, for allowing us to present our research. Today, I'll be speaking about our study investigating the effect of metformin on skin cancer survival. Next slide, please. Some background. A handful of studies have found that metformin is associated with increased survival in patients with various cancers. In skin cancer, metformin has been associated with a decreased incidence of skin cancers, and a 2023 study found a lower all-cause mortality in diabetic melanoma patients on metformin. Proposed mechanisms for how metformin acts on cancer cells include decreasing oncogenic insulin signaling and disruption of the metabolism of nutrient-hungry cancer cells through the modulation of oxidative respiration. So why is our study relevant to women? An interesting study published in Nature found a positive correlation between increased estrogen levels and UV exposure, which may indicate that some women are at an increased risk for skin cancers as a result of increased UV exposure. And another reason is that in many studies in oncology, and especially in clinical trials research, women are underrepresented. Our study made sure to include an equal proportion of women and men in each analysis so as to fairly apply the results to the treatment of women. And ultimately, our study aimed to compare the 15-year all-cause mortality between patients on metformin at the time of their initial diagnosis with cutaneous squamous cell carcinoma, melanoma, basal cell carcinoma, and Merkel cell carcinoma versus skin cancer patients not on metformin. Next slide, please. For our methodology, we used the Trinetics platform, which I'm sure everyone is familiar with now at this point. We used ICD-10 codes to identify each cancer cohort at the time of their initial diagnosis. We then used the National Library of Medicine's RxNorm code system to split each cohort into patients that are never on metformin or patients on metformin at the time of their diagnosis. We ensured metformin use for at least 1 year following the diagnosis in the metformin cohorts. We then used the propensity score matching feature of the Trinetics to control for differences in baseline demographic and health characteristics between the compared cohorts. Relative risks as well as Kaplan-Meier survival analyses were used to compare the rates of all-cause mortality in the 15 years following diagnosis. And next slide. So in an initial version of our study, we didn't include baseline smoking status and creatinine levels, but we felt it was critical to include those when comparing cohorts for overall survival. So here's the updated version of our characteristic matching, focusing on the 2 cancers that had significant results, which was squamous cell carcinoma and melanoma. This is a very busy slide, but it just goes to show that we were trying to control for many factors to validate the subsequent survival analysis. Next slide, please. So now for the results of our analysis, the initial version, like as I said, or the initial version of our analysis found that there was a lower all-cause mortality rate associated with metformin use in the Merkel cell carcinoma cohort, as well as the squamous cell carcinoma cohort. But in our updated analysis that I'm showing you here, we found that metformin was only associated with a decreased risk of 15-year all-cause mortality in the squamous cell carcinoma cohort. There was no difference in survival in the Merkel cell and basal cell cohorts. And interestingly, in both versions of our analysis, metformin use was associated with an increased risk of mortality in the melanoma cohort. And next slide. So in conclusion, peridiagnostic use of metformin was associated with a 6% absolute reduction in all-cause mortality in the squamous cell carcinoma patients over the 15 years following diagnosis. In contrast, the risk of mortality in those with melanoma was 8% higher in patients on metformin. These conflicting results may reflect the pathophysiologic differences between melanoma and squamous cell carcinoma. So future studies may prospectively investigate the effect of metformin on skin cancer specific survival, especially squamous cell carcinoma specific survival. I also believe our study underscores, just a personal passion of mine, the importance of precision medicine in oncology. Continuing to refine cancer treatments to as granular level as possible, such as specific metformin use for squamous cell carcinoma patients, will help contribute to better overall outcomes for our patients. And that's it. Thank you so much for your time. Any questions?
Thank you, Nick.
Thank you.
I believe I'm going to try one more time. Habib Bashir has not joined us. So if all of the presenters could put on their cameras, we're going to offer the opportunity for anybody to ask any questions, if there are any questions from the audience.
Not quite a question, but I just wanted to say thank you to everybody for presenting. I'm Ivanchi, I'm one of the WDS board members, and so many wonderful presentations tonight, and I learned a lot from each of you. So thank you for taking the time.
Thank you so much for having us.
Thanks, y'all.
Well, not hearing any questions, I do want to thank everybody for joining us this evening. I want to thank our presenters. This was very educational, and I know everybody on the call appreciated all of the information received. We will post this on the website. You'll get notification of that post when we do that. Thank you so much for your time this evening, and have a good evening.
Thanks, everyone.
Thank you.
Thank you.